Good afternoon, everybody. So that brings us to the next session, which is on chronic musculoskeletal pain. I have been mandated to set the tone, and I think I'll just start with one word: pain. Pain, possibly 80 to 85% of all the patients who come to, that's the entry point to our clinics. And when we look at the pain, basically we have three reasons for pain, irrespective of the label which we may choose to give. Inflammation. I think almost everyone in this hall is an expert on handling the pain that comes with inflammation. I think I'll give you all 10 out of 10. Structural reasons, if you are able to figure out, we can do some manipulations. We can take the help of our surgical colleagues, possibly get a PIVD surgery done or get the knee replaced and everything. 9 out of 10. But the third pain, centralized pain, which comes in the form of hyperalgesia, where the patient gets so much pain but he complains of so much. Or allodynia, where little bit, hardly, it's not a painful stimuli, but the person is just crying with pain. We find it very, 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 very difficult to handle it. Sometimes it leads to a lot of frustration on our side, and we kind of feel helpless. And we wish that this part of it is not rheumatology. That's not my job. Either it's a localized or a generalized pain. I love the inflammation part of it, where I can play around with DMRs and biologics and everything. This session is actually going to be focusing on the third aspect of pain, the pain that is chronic musculoskeletal pain, which has always been giving us a lot of problem. To conduct this session, may I now request the chairpersons to come to the stage. First is Dr. Mahendranath sir. Dr. Mahendranath sir is a senior consultant rheumatologist from Bangalore, and he was the past president of IRA in 2001 to 2003. I'll also invite Dr. Indira Menon. Yeah, Dr. Menon, she's from my alma mater, from Armed Forces Medical College. She's also the daughter of Brigadier Menon, the hall of which we are sitting. She's a senior consultant medicine, and she heads the critical care medicine in Bangalore Baptist Hospital. I'll also request the other speakers. A keynote address would be delivered by Dr. A.N. Malaviya sir. No introduction required. Father of rheumatology in India. Sir, please come over. We have Dr. Samuel Whittle, consultant rheumatologist from Australia. Dr. Whittle. Last but not the least, we have Dr. Sunita Kaidi, consultant rheumatologist from Hyderabad. Dr. Sunita there? Yeah, please come. Please, sir. Thank you, sir. I'm sure that all of you enjoyed the session on osteoarthritis, and I think we are tackling equally, if not a more vexing problem, and I shall not stand between you and the speakers. And I think we will start directly by inviting the keynote speaker, Dr. Malaviya sir.
Thank you, Shankar. Chairpersons, ladies and gentlemen, I wish to thank the scientific committee and especially the chairperson, Debashish Danda. I gave him 3 choices and I thought that he will give me something easier, but reluctantly I gave the possibility of a subject that I have been interested in for some time, which I consider was the most difficult one, so he chose that. I would have loved to give a talk on how to protect and prevent the heart against inflammation on statins, but that is what they mandate. It has been mandated, so I'm going to try my luck with this new concept. And ACR this year was full of it, the third pain. And it is being talked about all over the world. And in January at Ahmedabad, they have called me again among the physicians of India to talk about what is this third pain. With that, an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And this is the definition, official definition, formal definition. And this is the first pain which we learned on our first day in the medical school when we went to our physiology class. And we were told that whenever any organ, any area in the body gets damaged, there is pain, and this is a default, and it's a common sense understanding. And at that level, so what is so new? I mean, you get hit, it hurts, that's it. And that's what we understood on the first day when pain was being taught, and the physiology of pain when we were undergraduates. We were then also informed that it's very interesting, it's an alarm system. And it tells that there is some danger, that's why the pain is occurring. And the brain is being informed of this danger so that you can somehow evade or get out of this situation that may be damaging to the self, to the body, could be dangerous to life. And thus, the pain became an item which will save our life. It was part and parcel of survival of the race and the human being, as well as other living beings. And so, we immediately learned with this experience to avoid situations that will cause pain. In any future such situations, we will try to avoid that. And this was the pain we understood. There was nothing special. Pain and fever are the two first chapters in Harrison's textbook, because these are the two most common complaints with which the patient comes. So what's so new that we are talking about it now? Of course, there was underlying factual information that was taken for granted. It requires normally functioning somatosensory nervous system. Obviously, unless the nervous system is normally functioning, pain may not be felt the way we feel it when it is normal. Neurophysiological processes of feeling pain, this kind of pain, then came the term nociception. We feel this pain, which I talked about with the daily occurrence, any type of injury, this is nociception. We feel pain, this physiology is nociception, and this starts at the periphery where we have nociceptors. And I remember early days in physiology, all kind of receptors in the skin, it was so boring at that time. But now we realize there are 4 major types and how they function and what are the gated channels for conveying the current, etc. Now, at the level of these nociceptors, there is transduction. The transmission of this noxious stimuli, which will then carry this information chemically and electronically, or electrically rather, to the central systems where pain will be felt. This is the first pain. This is the ordinary pain. This is the day-to-day pain which all of us have experienced in our life, and we will call it first pain, the nociceptive pain. These are the receptors. Time is short. There are several types of them: mechanical, chemical, inflammation, temperature. And I slightly differ with Shankar. He gave the 3 pains. But now I'm going to give you a slightly different classification. Shankar, you were at this stage, and you defined this into 3 categories. But we put it all together in one pain, that is the first pain, that's the nociceptive pain. Once this pain is felt, let me try this, whether it works. From here down to the brain, or rather up to the brain, at the center where pain is perceived, there is a synapse at the dorsal root ganglion, and from there, through lateral spinothalamic tract, the sensation goes up to thalamus, and then reticular formation, and then thalamus, and that's where we feel nociceptive pain. And immediately we withdraw our hand if it is hurting, or we try to run away from the place, which could be dangerous because it is causing pain. So we have these receptors. These receptors, actually, when they are stimulated, there is a large number of, look at the number of chemicals that are secreted. Many of these are very well known to you, and I'm not going in detail. These are the chemicals which then lead to the sensation, which then is transduced, transported then through dorsal root ganglion synapse and goes to lateral spinothalamic tract and goes to the higher centers where pain is perceived. Now, let us just see this in a little more detail. So, tissue injury, it could lead to inflammation. Mediators are released and they are listed there, and I am not wasting time on that. This leads to the stimulation of the nociceptors, and they, through peripheral sensory nerves and via synapse at dorsal root ganglion, decussates on the other side, goes on the other side of the spinal cord, and up through lateral spinothalamic as well as medial spinothalamic tract, goes up to thalamus. And at thalamus, it seems to, it doesn't go beyond that. A feeling, it gets modified here, and then that modified sensation reaches the cortex, and based upon the situation, based upon our past experience, then either we start shouting, running, or we quietly say, oh, this will go away, just withdraw like that. And that is the modulation occurring at the level of the cortex. This is nociceptive pain that we are talking about. Then comes another thing. Don't worry, this pain is temporary. I'm taking a shot for protection against COVID-19. The caregiver is giving me a booster shot. It will hurt, but don't start shouting and running. And then the cortex says, suppress it. And these are the suppressing pathways, descending inhibitory pathways, and that is at the center of understanding the pain that I'm going to talk as the third pain. So pain can be modulated with experience, with situations, and this modulation suppresses the pain, and you can modulate. And if you really believe in yoga and other type of adhyatmic exercises, there are Rishi Munis who are supposed to completely inhibit this to the extent that you can cut their hand and they will not feel it. And that is the inhibitory pathway that we are talking about. And that, well, I will take a little more detail, will be the third pain. But remember this pathway going down here, inhibitory pathway, which will be visible in hopefully in the next slide. But let us just spend a little more time on nociceptive pain. In the skin, it is very well localized, while in deeper structure in viscera, it is rather diffuse, and therefore, when it occurs in the chest or in the abdomen, it becomes difficult to find out which particular organ is affected and cause of pain. Musculoskeletal tissue, therefore, are quite superficial, and quite often we can say the pain looks like occurring from a tendon. On the other hand, more deeper pain, bone pain and muscle pains are more diffuse and becomes difficult, yet they are all nociceptive pains. I will not go in detail with referred pain because of the shortage of time. These are sharp pain, the superficial ones, as against the dull, aching pains, and there are different type of myelinated or unmyelinated fibers that carry these two different sensations, the deep pain, which is more diffuse, as against sharp pain, which is very localized from superficial areas of the body. Pain is actually a subjective, very difficult to measure, and requires consciousness. Very interesting. Unless we are conscious, we can't really perceive pain. And that's where comes the adhyatmic aspect of pain. Maybe there is severe pain and the person says he's laughing. He doesn't feel pain. A sepoy on front line gets shot and he doesn't feel pain at all and he continues to fight. So signaling system, modulation from higher signals and centers, unique perception of the individual from background, his knowledge of the past and experiences from the past. Each person therefore feels and perceives pain very differently. How about then the second pain? This is a simple one. If you have a nerve damage, that's second pain. It's called neuralgic pain. It is found in diabetes, in nerve injuries, in accidents, all kind of neurological damage and damage of the nerves which carry sensations of pain is neuralgic pain, and I won't spend much time on that. So now you know what is second pain. And these are spontaneous pain, shooting, burning, stabbing, electric shock-like pain, evoke pain, pain occurring suddenly due to pain, in cold. And you ask the person with diabetic peripheral neuropathy, he will describe all typical forms of this second pain, the neuralgic pain. And I'm not dwelling upon that in any more detail. But these are some of the classic symptoms. And the neuropsychiatric features may get associated with type 2 pain, and then it turns into type 3 pain. That is the only importance of a neuralgic pain. If it persists and becomes chronic, and that's true of nociceptive pain also, any pain that becomes chronic has a tendency to become the third pain, which I will be talking about. I won't go into more detail. Cancer therapy, chemotherapy, nerve injuries, some drugs causing peripheral nerve damages. These are the neuropathic pains. So now we have two pains, nociceptive, you have understood, and the neuropathic pains. And that's the classification, and it was like that till 2016. There was no third pain in those days. But what about this? The patient comes, you have treated, patient had rheumatoid, there is no inflammation left. You examine the patient, the joint is normal, no local tenderness. But doctor Saab, I am not well at all. I have pain, your medicine is not helping me. I cannot sleep, I get up tired, I am having pain all over my body. What is this? This is a fibromyalgia. But now, this problem is increasing and increasing, and it has become one of the major issues, because if you are doing C-dye, S-dye, or DAS28 or whatever, patient global is a major component. And people have fought against it. Let us remove patient global, because it is interfering with reaching the actual complete remission. But Felsen and colleagues have really fought about it. No, you cannot remove patient's perception of pain. And that has to be made better before you can say the patient has become completely all right and has achieved remission. So we must understand what's going on. This is the third pain, the pain which we never realized or tried to treat as rheumatologists, who was interested only in treating inflammation. It is frozen. Can somebody help me? Please mind my timing, please. It's not moving. कुछ हो गया? क्या हो गया? पीछे जाएंगे तो पता लगेगा हम कहाँ थे. बस ठीक है, thank you. So, after these two, more widespread, more intense, multifocal, without any identifiable tissue damage, maybe with full of fatigue and sleep, memory loss, memory problems, my mood fluctuates, and we have this list. Fibromyalgia, pain amplification, chronic non-specific back pain, irritable bowel syndrome, chronic temporomandibular pain, Chronic primary bladder syndrome. I'll tell you some story after the talk. If you talk personally to me, I'll tell you something very interesting about it. Primary chronic bladder pain, very few people realize how severe. Talk to the urologist and they will tell you about it. Chronic primary pelvic syndrome, talk to the gynecologist. How often and how many such patients are coming to them? This all belongs to the pain which was not explained by nociceptive pain or neuropathic pain. And that is called third pain, caused by malfunctioning of the inhibitory pathway which inhibits the sensation of pain. And everyone here said that, oh, this is centralization of pain. That's a very easy way of understanding, but centralization is one of the ways of calling it, but actually it is malfunctioning of the inhibitory pathway which has been shown, and a very recent paper has shown that there is a biomarker that can be found in those who are having malfunctioning of the inhibitory pathway. And I can actually stop my talk at this stage because that's what I wanted to talk about. Remember, there is an inhibitory pathway which is not functioning normally. But just to show you, this is the pathway from, it starts somewhere about reticular formation and subcortical area and goes down like that. Hurts all over, excessive tenderness, fatigue, sleep, mood, absence of local systemic disease. These are the characteristics of nociplastic pain, the third pain. And the beauty of this pain is, this is a way of explaining, it may not be actually true, but it is like taking a photograph of pain and keeping it in your hard disk. And off and on it flashes. And suddenly the patient feels pain when there is actually no pain around. And this is what I would like you to understand. Pain imprint in certain areas of subcortical region of the brain, which inhibits, which makes the suppressive, the inhibitory pathway abnormal and keeps on flashing and showing these pains. And these pain persons are true sufferers. Once you tell them that I know all about your disease, you are not faking, it is true, its name is nociplastic pain, I think we can manage it. Never say we can cure it. Now I leave this to my next speaker, going to speak in great detail about this, but this is all in recent, one of the numbers of Lancet from where I have taken it. It goes in depth with the pathophysiology and psychology of chronic pain and where does it come from and how it interacts with social phenomena, interpersonal relationships, at the job, at home, during sleep, etc. A simple thing, you just do a CRP and ESR, do a good dedicated ultrasound to exclude actual inflammation which you might be missing in an area like ankle. In ankle, there is often, we feel there is nothing, and when you go through ultrasound examination, oh, there was actually inflamed tendon, or there is a big enthesitis there which we had missed. So once you are sure this is not nociceptive pain of inflammation of rheumatoid arthritis or similar disease, once you have excluded, then you can talk to the patient. Don't let them go through an ANA test and RNA. They will get a peg to hang upon their pain, the third pain. Doctor, you are missing it. I have the disease. The test shows ANA positive. You don't know anything. I'm going to the next doctor. And then the next doctor. Yesterday, my son called me. My friend's daughter is ultimately decided that we are all useless. They are going to Singapore for a whole body checkup because she faints every now and then. Examined by everyone, no disease detected. I said, this happens in girls who might be about 16 or 17 years of age. It will go away. No, they will go to Singapore for whole body checkup. That is what you should not do. Tell them not to do that. ANA positive is seen in Dallas Heart study in 30% of the cases, normal persons. So don't do that. X-ray routinely doesn't help at all. We have discussed all that. And now the new kids on the block, oh, but maybe my back pain is due to HLA-B27, not knowing that 6% of Indian population is positive for HLA-B27, and here comes uric acid. It is it's a warning signal that don't eat so much, keep doing exercise, don't drink that much, keep your health proper. But no, uric acid is high, and you are missing my diagnosis of gout. Remember ASO titer. My ASO titer, I said, in adults, what's the use of this? Now, treatment is a multidisciplinary approach. One of the things that I know about you, you have a true disease. It is nociplastic pain. And when I started doing these patients, really, doctor, you know the disease? The doctor-patient relationship gets established, and the patient starts believing in you. I have started doing it, and my colleague sitting, doctor, you never took interest in this. But during the pandemic, I made it sure that I understand third pain, and I'll start treating pain. You have to have your colleagues with you. Multidisciplinary team, these are well known. This is in Lancet. You can open it and read it. Treatment is a general guidelines. There are 4 drugs, which one is to be given. Remember just one little thing which my colleagues may not know. Duloxetine type of drugs must be given with breakfast. And now the nociplastic pain must be treated by a combination of drugs. Amitriptyline or milnacipran you give at night time, while duloxetine and similar drugs in the same category with breakfast. That's all I wanted to talk about. The next step is going to be a big issue, really big issue, and India somehow is falling behind, and China is taking over as usual. Cannabinoids are being pushed to a level while every Babaji takes cannabis, everyone was happy. Our forefathers always took a little bit of cannabis once they became old and they had aches and pains, and we are not pushing this to a scientific committee to test it and prove it in controlled trials. Das, it was one of the persons I named to the person who came to me. You go to Siddharth Das, he might be interested, because this in cannabinoids might be the future. And do you know, at ACR this year, there was a big talk by expert from, I forget her name, from Montreal, on the use of possible. Don't start using it, please, till it gets proven. Thank you.
Thank you, Professor Malaviya, for the enlightening talk. Now I request Professor Dr. Samuel Vettel from Australia.
We'll just take a 30 seconds short pause because of the technical glitch, and then we'll start the next session.
Doing that, how about I frame my talk for you, just so you understand what's about to happen in the next 15 minutes. So I wandered in here innocently today thinking that I'd finished all of my sessions, but one of the speakers for this session was indisposed, and I happened to mention to Professor Danda that I had a USB drive in my pocket that just happened to have a talk on fibromyalgia in it, and so here I am. So I'm very happy to share it with you. Here's the problem, it's a 1-hour talk, and I've got 15 minutes. So I can either talk at 4 times my normal pace, which is going to be really fast, or we'll just skip through. It contains 5 concepts. I'm just going to... Okay. I'm just going to use those concepts as food for thought for you. But if you want to hit me up later over the weekend so that I can expand on these in greater detail, I'd be very happy to. I'm happy to talk about fibromyalgia non-stop. So, as soon as the reboot's done, I will start. I'll frame it a little bit further for you. So essentially, my clinical interest is in fibromyalgia, so there it is. So I run a public hospital fibromyalgia clinic in South Australia. I've been doing it now for 17 years. So these are my sort of accumulated thoughts that help me to get by in my weekly clinics. So strap in, here we go. These are my disclosures. Nobody pays me to do this talk. I come from South Australia, from the land of the Ghana people who've been there for 40,000 years, and there's beautiful Adelaide with beautiful Adelaide Oval. So we know that fibromyalgia is a low prestige disease. It's the lowest prestige disease. And this is something that I find offensive and something that I'm trying to change amongst my trainees. But we know that this is a popular kind of thought amongst a lot of rheumatologists. Many rheumatologists don't think we should even be seeing patients with fibromyalgia. And I want to tell you that I don't believe that. So here's our 5 acts. Act number 1, it helps to have a philosophy. Who is this person? Does anyone know? This is Lao Tzu. Lao Tzu is the founder of Taoism. And one of the foundational concepts in Taoism is this concept of Wu Wei. And Wu Wei translates most simply as action through inaction. And this is one of the principles that really helps me in the clinic. Many of my patients to whom I don't usually prescribe medications and to whom I don't really do any tests, it feels like I'm doing nothing. But in fact, I'm deliberately doing nothing. So my action is inaction. And I'm really trying to protect many of my patients from this sort of thing. Now, this is a visual pun. This, of course, is a CAT scan. Thank you. Thank you. So I'm trying to protect people from over-investigation. So what I like to tell my trainees to do is to listen hard to the patients, but you don't have to do anything. That's Act 1. Act 2. Fibromyalgia, the term, is a description. It's not an explanation. And I say this to my trainees over and over again. I don't think they ever understand what I'm saying. But we know there's a lot of controversy about the term fibromyalgia. It's only been in use since 1976. Before that, it was fibrositis. Before 1904, it was neurasthenia. It's been called many other things. And names carry a lot of power. And we know that fibromyalgia is more than just pain. It's all these things. It's a whole syndrome, including brain fog. So that brings in this controversy. Is it even a real thing? We know there's all of these central sensitivity syndromes that all have these 3-letter acronyms. So we've got all these names for all these things that overlap. Are we just making diseases up for ourselves? And I say that we don't. And so this is the philosopher who's helped me the most to understand this. And I won't go into the detail about this man, but this is Ludwig Wittgenstein, who is a famous philosopher from the early 20th century. And he invented this concept of language games. And essentially a language game implies that when we use a term, it doesn't really map onto a concrete concept in the world, but it's a form of use that's developed socially. And so what he said is so words don't actually necessarily mean a thing, but they still have value and they still have power. So what he said is we must do away with all explanation and description alone must take its place. And so when we use the term fibromyalgia, we're describing a set of symptoms to help us organise our thoughts. But in fact, the word fibromyalgia does not explain anything. So it doesn't contain any causal valence. So what I say to my patients is the fibromyalgia is our explanation for your symptoms, or our description of your symptoms, but fibromyalgia is not a cause of anything. So fibromyalgia is a conceptual framework. It's not the disease itself, which is paradoxical and hard to understand, and sometimes you just have to let these things wash over you. So the third act is around how this construct that we have of fibromyalgia is evolving. So we all know that we've kind of progressed from this categorical definition of fibromyalgia into this more continuous measure of fibromyalginess. And we know now that even if you don't fit the diagnostic criteria for fibromyalgia, that you can still have a moderately high fibromyalginous score, and that this predicts your outcomes in all other areas of medicine. So in people who have arthroplasty, the higher your fibromyalginous score, the more postoperative opioid you need. So in fact, all of my colleagues who think that they don't see people with fibromyalgia, see people with fibromyalgia every day. And it's on all of us to actually equip ourselves with the skills to treat fibromyalgia, even if we don't want to see people with fibromyalgia alone, because all of our patients in our inflammatory diseases clinics are going to be influenced by this condition as well. Okay, here's my fourth act, systems. So I think one of the difficulties that we have in understanding fibromyalgia is that it is not a linear disease that can be understood from a reductionist scientific perspective. What do I mean by that? Diseases that are easy to understand are linear. So, bacterial infections are easy to understand. You inhale a pneumococcus, it goes into your lung, it creates an infection, you get lobar pneumonia, makes you short of breath and febrile and cough. We do an X-ray, we diagnose it, we give antibiotics, the end. So how do we conceive of diseases where we can't see any structural pathology? This is the great challenge for all of these diseases like fibromyalgia. And what we've tended to do in the past is just say, well, if we can't see it, it must be in your head. And of course, we all know that that's an oversimplification. It's far more complicated than this. So early in my career, I thought, I can't understand fibromyalgia. So I thought, I know what I'll do. I'll make a mind map. So I started making this mind map. This is the first and last time I've ever done a mind map in my life, because I got this far into it, and I thought, I really don't understand fibromyalgia. So I stopped. But what I actually drew inadvertently is a complex system. And I think that was the insight. We're actually dealing with a disease of complex systems. And we know, in fact, that we've got pathology in fibromyalgia at multiple levels. We know that there are genetic abnormalities, epigenetic abnormalities. There are disorders of the peripheral nervous system, the autonomic nervous system, the central nervous system. We know there are neurotransmitter differences. We know there are endocrine differences. And we know now that there may even be an autoimmune basis to this, because you can passively transfer fibromyalgia from humans to mice. And the antibodies attach to the glial cells in the dorsal root ganglia, which is exactly what you'd expect them to do, if indeed this was an immune-mediated disease. So it's not true that there's no structural pathology in fibromyalgia. There is lots of structural pathology, but it's still hard to understand how that evokes the disease that we see. And I think the answer is that it's non-linear. And the way I like to think about this is through the lens of complex systems theory. Now, I don't intend to explain complex systems theory to you today in my remaining 7 minutes. But any of you who are interested in this topic, I think it's really worth doing a little bit of reading about complexity theory. Because complex systems exist on the edge of chaos, and they have a number of features. So we're complex systems. We contain complex systems. Our central nervous system, our autonomic nervous system, our immune system are all complex adaptive systems. And we exist within a complex adaptive system. This room is a complex adaptive system as we're all melding our minds together. And complex systems have a number of features. They're mostly resilient to change. That's their main thing. They adapt. But they also have emergent properties. So consciousness is an emergent property of the brain. Pain is an emergent property of the human organism. And those complex systems can undergo a sudden and unexpected phase shift. And those of us who see people with fibromyalgia know that it's very common for people with fibromyalgia to spend many years of their life not having fibromyalgia. Then something happens that can be innocuous, and then they've got fibromyalgia. And then they've got fibromyalgia, most of them, for the rest of their life. So something in the organism changes suddenly, dramatically, and unpredictably. And that is a feature of a complex system. Okay, so now I'm going to commit some heresy as a result of my interest in complex systems. And this heresy is that I'm a bit suspicious of the biopsychosocial model. And I think the biopsychosocial model was fantastic when it was invented. But I think we've got a problem now. Because I think when we say that we should treat people from a biopsychosocial perspective, but in the clinic, what that often turns into is that we degenerate it into this dualistic concept, that people either have a biological problem or they have a psychosocial problem. So the BPS was designed to avoid dualistic thinking, and I think we have mapped dualistic thinking onto it. When in fact we need a much more nuanced and systems view of it. And so the conceptual framework that I'm most fond of at the moment, and you may or may not have heard of it, is this concept of enactivism, which is sometimes also known as a 4E cognition approach. And the 4 E's are embodied, embedded, enactive, and extended. So what that means is that we conceptualize of humans as being an embodied entity We have a body that is in the world, it's embedded in the world, and that we actually make sense of the world by moving in the world and interacting with the world. And then we extend our cognition through all the devices that you're all holding in your hands and extending your cognition with right now. Now, why is this important? It's important because the enactivist approach infers that the organism is constantly on the lookout for threats from its environment. And we in medicine often inadvertently contribute to the sense of threat that I think helps to perpetuate the symptoms of people with fibromyalgia. So this is a little game I like to play when I examine our medical students in their Viva exams, is while they're interacting with the patient, I like to write down a list of all the harmful metaphors they use while they're trying to counsel a patient. And this was a rheumatoid arthritis counselling station. This was really talking about methotrexate. But these were all the harmful metaphors that all these people invoked. And these are terrible words. Terrible words. Irreparable, aggressive, nasty, scarring, malformations, destruction, and strike you down. And these are our medical students trying to do their most beautiful counselling. So we use these negative metaphors all the time, and they help to perpetuate the sense of threat that people with fibromyalgia experience. So I think one of the things that we can try to do is to reduce the threat valence by using more helpful metaphors in the clinic. So in my clinic, you're not allowed to say wear and tear. In my clinic, you're not allowed to refer to osteoarthritis as degenerative disease. Imagine being told that you're degenerative. So we're trying to flip to more positive metaphors. So, take-home message: if fibromyalgia is a disorder of complex systems in unique organisms, single interventions, typically medications, are probably not going to work, and that's exactly what we know to be the case at the moment. So in our clinic, we base all of our treatments on 3 non-pharmacological pillars: movement, sleep, and thinking. And finally, fibromyalgia is common, but it's expressed individually in individual humans. So if you look at this through the prism of Western art, which I love to do, here's a painting by Iracon, a French painter. This was painted in 1819. That was threatening. It painted in 1819. And this is humans dealing with the great power of the ocean. And then this is another human creating art at almost exactly the same time. This is Hokusai in Japan. This woodcut was produced in 1831, so only 12 years different from Iracon. And again, this shows humans dealing with the majesty of the ocean, but it's such a different representation of it, and yet both of them make sense to us as humans. And so I think taking a history from our patients that incorporates their unique humanness and their unique first-person perspective is the key to helping them navigate the way through their fibromyalgia experience. So, to finish, and remarkably I've managed to do this on time, it helps to have a philosophy. My philosophy is Wu Wei, action through inaction. Fibromyalgia is a description of symptoms, not an explanation for them. Fibromyalgia is a good way of thinking about all of our patients, not just those in the fibromyalgia clinic. I think it really helps to understand fibromyalgia, to think about it from a systems perspective, and ultimately, fibromyalgia is an individual experience with common elements. Thank you.
Thank you, Dr. Samuel Whittle. Now we move on to the last topic, very interesting one. Debashish has given a mandate: brainstorming a big doubt. Opioids, cannabinoids, and benzodiazepines, do they not constitute the trio of bad medicines for chronic pain? Sunita Kaidi, consultant rheumatologist at Yashoda Hospital in Hyderabad, is here to clear your doubt or create some more doubts.
At the outset, I'd like to thank the organizers for giving me this opportunity. Well, with the previous two talks, all of us have understood that it is a difficult task to manage chronic pain, basically because the main thing is that we have to understand what is the cause of the pain, and also with the available therapeutic armamentarium, we have to understand that which medication that we have to use. So now today I have been given a task to see like whether opioids, cannabinoids and benzodiazepines, do not they constitute the trio of bad medicines for chronic pain. Coming to the first drug, that is opioids. So when we look at the evidence of opioids in chronic pain, this is a systemic review and meta-analysis of opioids in chronic osteoarthritis, and we have a Cochrane review of opioids in chronic back pain. So what these evidence tell us is opioids in chronic pain, we have very low to low level of evidence, and this is also of short-term efficacy. And when we look at this efficacy, it is moderate for pain, and for function it is very small when we compare this with placebo. And this effect is only for the short-term period, that is mostly for 4 to 6 weeks was the duration was studied in most of these studies, and the long-term efficacy of opioids in chronic pain is not proven yet. And coming to the dose of the opioids, around 50 to 90 morphine milli equivalent per day was associated with the improvement, and less than 50 was not shown any improvement in these studies. And coming to the opioid and non-opioid combination, the combination of the opioid and non-opioid was shown to have some improvement versus the opioid alone. And there are some studies which had compared the opioid to non-opioid medication. In these studies also, there are like weak opioids, for example, codeine and tramadol. They did not demonstrate any efficacy in the chronic pain. However, the strong opioids like morphine and oxycodone, they have shown some significant in the decreasing the pain severity. However, when we see the difference between the opioid versus non-opioid, they have not shown any difference in terms of the pain or function and other short-term outcomes. Then coming to the cannabinoids, we have like various preparations of cannabinoids which are available, mainly as Ayurvedic preparations, as just now Malavia sir has told. So, however, the studies whatever done on cannabinoids are basically on these two products, that is cannabidiol and delta 9 tetrahydrocannabinol. So, whatever the studies were done, or very less like 1 or 2 studies done on each of the diseases. Coming to the osteoarthritis, there is like 2 preparations, 2 topical preparations of the cannabinoid gel were compared with the placebo, and they have shown no difference in the primary endpoint of the pain reduction. In hand osteoarthritis and psoriatic arthritis also, oral preparation of the cannabinoid did not show any significant difference. And in rheumatoid arthritis, there is a combination of the cannabidiol and tetrahydrocannabinol was tested, and they have shown improvement in the pain and rest. However, it was not significant. And in this particular study, the background therapy was continued. So how to draw the conclusion was difficult. And coming to the fibromyalgia, there was one study where inhaled cannabis was used, and it was also shown mild reduction in the pain. These are some of the ongoing trials on cannabinoids, basically in knee osteoarthritis and also post-operative pain in the knee osteoarthritis. So we have to decide after the results of these trials, like whether we have to use cannabinoids or not. Coming to the benzodiazepines, these are some systemic reviews done for low back pain, and also systemic review done like where the benzodiazepines are included for muscle relaxants. This particular review, Cochrane review, was done by Samuel Whittle sir. We are very fortunate to have him here. So what they have shown is the benzodiazepines are very ineffective in case of low back pain, radiculopathy and rheumatoid arthritis. And in spite of not having any improvement, they are also associated with significant adverse effects, mainly in the form of drowsiness and dizziness, even when used for very short duration, that is for 24 hours in some studies and 2 weeks in some studies. Coming to the adverse effects of these 3 drugs, they have common the neurological adverse effects like somnolence, dizziness and headache. As all of us know, like opioids have predominantly constipation, and as a side effect on higher doses it may cause respiratory depression as well. And long-term use, they have shown to have people have abuse, addiction and overdose. Cannabinoids, basically the important thing to remember is they have a lot of interactions because it is a substrate for CYP, 2C19 and 3A4. So it was found to have interactions with tofacitinib and clopidogrel. Benzodiazepines mainly have a lot of CNS defects and have dependence and withdrawal and persistent or chronic use. Coming to the opioid and benzodiazepine combination, so this was a drug abuse survey, drug abuse updates of US, which had shown that when opioids are given along with the benzodiazepines, there was 10-fold increase in the risk, and there were 30% of the opioid associated over deaths when they have also used the benzodiazepine. So after this study, the CDC has advised against the concurrent use of benzodiazepine with an opioid. So this was about US. Like when we come to the India, this was the survey which was done in India in 2019, which shows that around 1% of the population aged between 10 to 75% have misused pharmaceutical opioids, and around 0.2% of them, which constitutes around 2.5 million people, are actually using pharmaceutical opioids. So this is not, I mean, this particular thing has to be emphasized, because for most of the patients we will be prescribing tramadol for tramadol or paracetamol combinations for pain, but they will be using it as they are available inadvertently by the pharmacies. Coming to summarize, like opioids have very small improvements in pain function in short-term users. We don't have any evidence on long-term effectiveness, and these have dose-dependent adverse effects too. And benzodiazepines are predominantly used for anxiety and sleep issues related to the chronic pain, and they have not showed any effectiveness, and instead they have more risk of drug dependence and withdrawal and overdose. Coming to the cannabinoids, we don't have any evidence to support the use. We don't even have a particular dose of the drug to use for any musculoskeletal conditions, and there are a lot of over-the-counter products which are available, so there are a lot of quality concerns about these drugs and also interactions. So with this, like it's better not to use these three drugs. They're definitely the bad drugs for chronic pain. So what to use? So when we have a patient with chronic pain, better to avoid these drugs and go for the non-pharmacological intervention first, like physical, behavioral therapies or yoga. Then if somebody is not improving with these medications, we may have to go for any non-opioid medication like NSAIDs or the paracetamol, or we can use selective antidepressants or selective anticonvulsants, which have shown almost equal or more than equal efficacy when we compared with the opioids. And the next would be the using of the combination modalities like non-pharmacological or pharmacological, or doing some interventions like intra-articular injections in those who require it, or epidural injections for the chronic back pain. And for any individuals with the chronic pain, as the previous speakers have told, we have to see what is the cause of the pain and what is the type of the pain, and the individual risk assessment has to be done. And most of these patients would be elderly patients with lot of comorbidities, so individualized treatments and side effects monitoring should be done. To conclude, are really these three are the bad medicines for chronic pain. So in my opinion, I feel like benzodiazepines, they are not useful and do more harm. They're basically prescribed for mood or the psychological complaints related to the pain rather than for decreasing the pain. And opioids, though they have some benefit and evidence for use in chronic pain, they are also associated with risk. So it's better to use them in special situations. And cannabinoids, they are like future with very limited evidence. So I'll conclude here, and I'll hand over to Mahendranath sir for his words of wisdom. Thank you.
Thank you, Sunita. Hello, can you? Hello? This movie. I don't know what words of wisdom I can say after Malaviya has shed all the wisdom on us. He is my guru, so I don't think I can say anything. The first slide. Mahendranath, after this. No, not. Sunita, was it in the, you were this thing last, no? Yeah. Yeah, pain is more than nociception. Pain is affected by emotions, genetics, and the context of a person's life. This quotation is from Delia Chermonte. She is the professor of integrated and palliative medicine in Baltimore. And she recently wrote, and it's connected to person's life, that is social connections, current circumstances. Pain is not always about tissue damage. There is a part that the brain based, and what the brain decides in terms of threat can either increase or decreases the pain. So a big part of chronic pain management is educating our patients about the top-down effect of the brain on the pain. Central sensitization plus negative cognitions like catastrophizing the pain, fear of pain, and hypervigilance lead to pain amplification and increasing disability. Use of the effective dose in least minimum quantity for the shortest duration possible. Do not be in a hurry or try to use any new medicine or drug that comes out to market. Let your experienced peers try and learn from them and use. Painkillers are plain killers that applies to every medicine and every drug. Thank you. Any questions? We can take one or two questions to Dr. Malaviya and Samuel Whittle. Please be kind, don't ask painful questions. Thank you. Yeah, we can take few questions.
No. Pain, nowadays everybody's talking about personalized ICU, personalized everything. So even the opioids, benzodiazepines and cannabinoids, can it be personalized? Because each patient is different. If I was 85 years old, please give me cannabinoids. That's what I feel.
Currently, it is not advisable to go for cannabinoids. We don't have any drug also which is available. We don't have any strength.
She's talking about an 85-year-old person who is,
Yeah,
maybe, are you looking at a palliative angle? Then
Not
the whole question.
palliative, just comfort without
We don't have any medicinal products which are available, ma'am. We have only Ayurvedic oils or the gels.
deep brain stimulation. They're talking a lot about deep brain stimulation. Okay.
Maybe when we are talking, maybe it is.
Oh,
everyone
sorry.
can hear.
Deep brain stimulation. Do you know anything about it? There are people doing deep brain stimulation.
But there was one little thing which I wanted to say. We are not authorized to write cannabinoids, and opioids we have already heard about. A very simple possibility. There are many PhDs and working in high places in different laboratories, Ayurvedic laboratories. Why should we shun them completely? I tell the patients that, look, I cannot do much about it. These are some of the telephone numbers. They are doing some research. Why not go there? And then I often get feedback, good that you told us, and my back pain has disappeared completely with whether placebo or whatever, I don't know. But I think we should encourage the alternative system people also to get correct patients so that we can conduct, our scientists can in the alternative system can conduct really scientifically evaluable trials like China is doing. Why are we falling behind in our own areas? We will not prescribe because we are not authorized, we don't understand that.
I think this has been a most illuminating session. I think actually I for one learnt about the nociplastic pain, sir. And I'm really, I think the system's approach to fibromyalgia, I think it's an eye opener, and possibly all of us can reread fibromyalgia with that angle. And with that, we come to the end of the session. Thank you very much for being to all the faculty and for all the audience for being such a patient listener.